Get started, I want to welcome everybody to another Pediatric Grand Rounds webinar. Just to remind everybody, we're using the webinar version of Zoom, and so we will be taking questions during the course of the presentation, and Sandrine van Schaik will be, I think, collecting the questions and posing them to our speaker today. So please use the Q&A button, not the chat button, if you have questions. And with that, I'd like to turn it over to Sandrine to introduce our speaker for today.
Thank you, Rafi. Hi, everybody. Sandrine van Schaik here, Vice Chair for Education. I am extremely pleased to announce a speaker and a topic that is a variation, a diversion of our COVID-19 topic. So we're going to talk about something quite a bit different. Morna Dorsey is our speaker today. Morna is a professor in allergy and immunology and the Catherine Group Endowed Chair, as well as Section Chief for Pediatric Allergy and Immunology. She's been at UCSF for quite a while, since 2013, and joined us from the University of South Florida, where she did most of her training in pediatrics, allergy, and immunology, with a brief stint at Boston, where she got a master's in clinical research. She graduated from medical school, from Harvard Medical School, before she went to Southern Florida, and we're very pleased that she since then has decided to come to UCSF and stay at UCSF, where she's not only a immunologist, but an allergist, but also the, as I mentioned, division chief and the fellowship director for allergy immunology. Morna is clinically working a lot with patients with immunological deficiencies, but increasingly has developed a passion for pediatric allergies. And as she told me, this is mostly because she realized how prominent and frequent these allergies are among children, and that she can have a much broader impact, both clinically and with her research, by focusing on this problem and this patient category. And she is going to discuss her research with us and the most recent advances in pediatric allergies. And with that, Morna, normally we would clap here, but I'm handing it over to you.
Hello, everyone. It's such a pleasure for me to be here with all of you. Thanks so much for that really kind introduction, Sandrine. I really do think I've got the best job in the world, as Sandrine pointed out. I have the opportunity to care for patients with very complex and rare primary immunodeficiency disorders, but at the same time, I have the opportunity to care for patients, you know, in a broader sense, those affected by allergy. And I've always been driven by, I think, finding therapeutic modalities, whether it be, you know, gene therapy for chronic granulomatous disease, or in this instance, immunotherapy for food allergy. So we're talking about a different kind of a epidemic. It's not SARS-CoV-2. We're going to be talking about food allergy today and immunotherapy for food allergy. Let's see here. Okay, so here are my disclosures. I receive institutional research support from Immunotherapeutics as well as DBV Technologies. I also receive support from the NIH, UCOP, CIRM, and the Immune Deficiency Foundation. So I often think about this child. This is a child who I saw years ago, and she drew this picture in my office because she was so distraught over what had happened. She essentially had a moderate to severe case of anaphylaxis following ingestion of a pretzel filled with peanut. Of course, she didn't know peanut was in it. And she required 2 rounds of epinephrine. She ended up in the hospital overnight. And clearly this had an enormous psychological burden for her. And she drew this picture and left it with me. And it reminds me of the important work that we do. But it also reminds me that there is a lot of morbidity associated with food allergy. Maybe there isn't a lot of mortality, but I think the burden, psychological burden of food allergy is sometimes underappreciated. And if you think about what we ask our patients and families to do, we are essentially asking them to be first responders to an emergency situation, and to assess sort of, whether or not epinephrine is needed if someone's severe enough, if the reaction is severe enough that they need epinephrine. Not to mention kind of the unknown risk of anaphylaxis that can occur with each meal. So I want to just kind of start off the talk by emphasizing that this really is a large psychological burden for our patients and families. So the objectives will be to identify key types of allergen immunotherapy, recognize the need for an individualized approach to allergen immunotherapy for food allergy. So it's really interesting if you think about the sequential rises in different allergic diseases that we've been experiencing in this country. We can start off by looking at way back in 1870 when hay fever was really first defined. And then in 1911, immunotherapy for hay fever was started. So we've been doing this for a while. And it was really then that we started to see kind of an explosion of allergic rhinitis with lots of folks affected. This became such a problem that in 1946, ragweed there was a systematic effort in the city of Manhattan to really eradicate ragweed altogether. In 1968, we started to see the increases in pediatric asthma. And then in 1995 was the first recognition of this rise in food allergy, and in particular, peanut allergy. And at the time, it was really noted to be found in industrialized, westernized countries. But now that's not the case. We're seeing it more and more across the board. And then we continue to see sort of this peak asthma prevalence and severity that is ongoing. So the CDC really recognized this as an epidemic. 30% of all adults and 40% of children in the US are diagnosed with allergic sensitization. And there's been an approximate 50% increase in the prevalence of food allergies over the course of about a 14-year period. And there are estimates that are about 6 million US kids are affected with food allergy. So this could have been the shortest grand rounds ever. We found the cure. We identified a way to tolerize children against peanut allergy by introducing it early. We now understand the concept of having cutaneous exposure to an allergen before oral exposure to an allergen, and how that might shift the immune system to develop hypersensitivity. And so to kind of follow up on that theory, we are all familiar with sort of the LEAP trial and the recommendations to introduce highly allergenic foods, or in this case, peanut, early within the first 4 to 6 months of life. And with that, there was the LEAP trial demonstrated a relative risk reduction of 96% for the development of peanut allergy. So really profound findings in this particular study. If we think of where the feeding guidelines were back in 2000, we were sort of postponing everything. And then in 2016, with sort of that LEAP trial, we've made this seemingly minor adjustment, a couple of months early now, really promoting the introduction of highly allergenic foods early in infancy. And I'd like to give a shout out to our general pediatrics group for really adopting these guidelines and promoting them for our families. So if tolerance is the optimum state, and that would imply kind of the ability to consume unlimited quantities of the food allergen, and for it to be a permanent state, that would be kind of the goal of allergen immunotherapy. But it really isn't the reality, because the reality is way down here, and that the current state of allergen immunotherapy is allowing us to achieve some level of desensitization. And that implies kind of a temporary state. It also implies the need for continued exposure to the allergen. And that really what we're doing is raising the threshold for a reaction. We're not curing anybody, we're not tolerizing anybody. And that threshold is really variable based on the type, sort of the method of immunotherapy that one chooses. A step up from that, to sort of bridge between reality and what the optimum state is this desired state of sustained unresponsiveness. And it suggests that one can consume larger quantities, and that the unresponsiveness is long lasting and it's in remission, but it's not true tolerance. And so some studies have demonstrated that this is achievable. For instance, some of the trials for egg allergy have demonstrated sustained unresponsiveness, particularly after long periods of treatment. So this is the optimum, this is the reality down here, and we're seeing some patients, a subset of patients, being able to achieve sustained unresponsiveness. So let's, as we continue to lay the groundwork for the discussion today, I want to talk about the different types of allergic conditions, because not all allergic conditions are amenable to desensitization. So if we talk about allergic rhinoconjunctivitis, we can achieve sustained unresponsiveness and tolerance. And we've done that through subcutaneous immunotherapy to environmental allergens, not to foods. And then we also have the ability to desensitize through the sublingual method to environmental allergens. And that's currently FDA approved in children for grass pollen. In adults, grass pollen, dust mites, and ragweed is currently approved. There are no desensitization or immunotherapy treatments for eosinophilic esophagitis, although there is some exciting work in the pipeline looking at whether subcutaneous immunotherapy has an impact on eosinophilic esophagitis. Now, remember, that's not a type 1 hypersensitivity. That's kind of a blend between type 1 and type 4, or sort of a delayed type hypersensitivity. So it's not really amenable to desensitization or immunotherapy. And then we're really looking at food allergy, the type 1 or IgE-mediated food allergy, as the type of condition, allergic condition, that we have good data that suggests we can desensitize. We can't do any immunotherapy for non-IgE-mediated food allergy. FPIES, that's not something we can do at the moment. Atopic dermatitis, that's also kind of a blend between type 1 and type 2, although immunotherapy for dust mites is a consideration in patients that have eczema and are allergic to dust mites, but nothing for food. And then many of you are familiar with our drug allergy desensitization protocols for patients that come in for needing antibiotics. So this is kind of the list of conditions that are amenable to desensitization. Remember, it's the type 1 hypersensitivity reactions, but really not the delayed or type 4 hypersensitivity reactions. So what makes up a food allergy in this country? These, top 8 foods are the ones that cause 90% of all food allergies. So we've got milk, eggs, peanut, tree nut, shellfish, fish, wheat, and soy. The good news is that for milk, egg, and wheat, those are the ones that children are more likely to outgrow. The things that you're more likely to sustain is sensitivity to peanut, tree nuts, shellfish, and fish. So, you know, somewhere in the order of 17 to 10% of children will be able to outgrow peanut allergy. So what makes foods allergic? There are a couple of biochemical factors that promote allergenicity. If it's a small molecular weight, if there are linear epitopes that are recognized by IgE antibodies, if there is glycosylation that occurs, you know, if we think about the Maillard reaction that occurs with roasting peanuts, that makes them more allergenic. Any resistance to denaturation, if it's abundant in the food source, and if it's soluble in water. Well, let's talk a little bit about what happens in a type 1 hypersensitivity reaction. In the upper left-hand corner, we see an allergen that's taken up by this antigen-presenting cell, and it sort of presents these little peptides to a Th or CD4 positive T cell, which then further instructs B cells to start to really produce antigen-specific IgE molecules. And when this then becomes differentiated into plasma cells, then it's really cranking out lots of IgE molecules. And what happens in an allergic reaction is that these IgE molecules that are sort of resting on the surface of mast cells and have docked on the surface of mast cells and basophils, when they become cross-linked by an allergen, that's when degranulation occurs, and you have the release of histamines, leukotrienes, and other mediators. And so that results in the reactions that we see. We see the hives, we see mucus secretion in the airways, we can see vomiting, shortness of breath, and then in more severe cases, shock and a fall in blood pressure. So what's our current standard of care for food allergy? Well, we say, you're allergic to X, Y, and Z, please avoid. And we give you an anaphylaxis action plan. We give you a prescription for your emergency management medications, epinephrine, antihistamine. And that was really for the longest time, that's really all we could do. And I think we all agree that leaves a lot to be desired. But more recently, we've been saying, okay, we have a primary prevention method. Let's promote early introduction. And then as of this year, the FDA has approved peanut oral immunotherapy. So the very first treatment for food allergy approved in January. And we'll talk about where that fits in the overall model of how we're going to take care of a patient with food allergy. And then there are other investigational treatments that are out there, and many that are in clinical investigation. So, you know, we could say, fine, go home, let's just avoid these foods. But in reality, we're seeing that children are going to get exposed on a regular basis. So this is looking at children followed over 5 years by a survey. And of the patients who were able to respond to the survey, 60% of them had an accidental exposure to peanut. And the places where the accidental exposures occurred were across the board. We saw some in restaurants, in school or work, at a friend's house. But then the largest proportion occurred at home. And these are vigilant, families, educated, they know what they're allergic to, but these things can happen, and they happen with some frequency. So how much peanut is in an accidental exposure when we're talking about these events that occur? In a survey of peanut allergic patients, the amount of food allergen that triggers the accidental reaction was able to be estimated in about 238 participants in this one survey. And the median estimated eliciting dose in real life was 125 milligrams, with a range of about 34 to 177 milligrams of peanut protein. What does that mean in terms of how much of a peanut kernel? Well, the average peanut kernel contains about 250 to 300 milligrams of peanut protein. So it's really about half to 1/3 of a peanut kernel that can elicit a reaction. And in terms of where the doses across the board here, we see some reacting in as little as less than 5 milligrams, and then 5 to 50 milligrams was also a large response. So we know that the prevalence of peanut allergy is increasing. We see that this is also the case for the other highly allergenic foods. But we also are dealing with an increase in the severity of reactions. So this is looking at a course of about 7 years, and the severity of reactions has increased. So those patients needing epinephrine, needing to go to the emergency room, needing to stay overnight in the hospital. So now that we've established that tolerance is not easily attainable, the new focus has been on increasing the eliciting dose. So tolerance is not achievable. Maybe a subset can have some sustained unresponsiveness, but what we're really trying to focus on is increasing the threshold of reaction. And does that really mean anything? Well, there's been some modeling studies in the real world, using real world examples of how patients might encounter peanut in different food products. And so for someone who would have originally reacted to 3 milligrams if they underwent immunotherapy and raised their threshold to 300 milligrams, that would constitute a 99% risk reduction in the development of anaphylaxis. So that may be meaningful for some and not so meaningful for others. Let's take a look now and focus on kind of allergen immunotherapy. And it turns out we've had a long history of it. We've had a long love affair with allergen immunotherapy. And we really started this back in 1908. So let me just orient you to the slide. So the top is immunotherapy for foods, and the bottom in the blue is immunotherapy for environmental allergens. So in 1908, there was the first report of oral immunotherapy to treat food allergy, and that was in a 13-year-old egg allergic young man who ended up being able to consume a whole egg at the end of the dosing. And then in 1992, there was a double-blind placebo-controlled study of subcutaneous immunotherapy for peanut allergy. And this was wrought with lots of side effects, a lot of systemic reactions occurring with this particular method. In 2003 was the first report of SLIT for food allergy. And then in 2010, a proof of principle study, pilot study, was used for epicutaneous immunotherapy in food allergy. And then finally, we have the FDA approval of OIT for peanut allergy in 2020. So there can be different approaches to inducing allergen desensitization based on different sites of allergen exposure. So gut versus buccal versus epicutaneous. So OIT versus SLIT versus epicutaneous. Subcutaneous immunotherapy, I'm going to take that off the table because that really hasn't, that isn't really in any sort of phases of clinical trials. And that seems to be probably the one that elicits most reactions. But there are structural and functional differences between the oral mucosa, the gut mucosa, and the skin. And these result in different immune responses following allergen exposure. And the differences include a variety of things, but mainly the type of antigen-presenting cells that are involved in allergen capture, the structure of the epithelial barrier, and the level of vascularization. So all of these factors are related to kind of degrees of side effects and degrees of efficacy. So what happens when you achieve tolerance? Really the main goal is to kind of increase the T regulatory, the allergen-specific T regulatory cell population. And while we expect to see this intolerance, we haven't, I think the jury's still out on whether we are seeing this in the desensitization models. In other words, is there really a big difference in the population of T regulatory cells in placebo versus immunotherapy treated groups? But it's worth mentioning that T regulatory cells play a central role in the development of tolerance, and they do that because they're able to influence B cells to decrease peanut-specific IgE, induce these blocking antibodies, IgG4 antibodies. They can suppress inflammation from dendritic cells, as well as Th2 CD4 positive cells, and then downregulate some of these pro-inflammatory cells of the innate immune system, including basophils, eosinophils, and mast cells. But what really happens during kind of the desensitization process, I'm not going to go into the top panel because we've kind of discussed that already. But in the early stages, during the sort of the initial escalation and buildup phase, you'll see kind of an increase in the IgE production. And in a way to combat that, IgE is endocytosed at an increased rate. And then there's actin rearrangement that can occur to sort of blunt the response from mast cells and basophils. And then in sort of later on in the consolidation phase, you begin to see this out-competing with IgG4 molecules. And IgG4 is really important because it can neutralize allergens, and then it can also engage in Fc gamma R2, which is an inhibitory receptor, and then sort of downregulate the response through the high affinity IgE receptors. So just kind of to summarize, in the initial phases, you're going to see a high, kind of an increase in the IgE, and that's why, for instance, for sublingual immunotherapy for grass pollen, we say don't start it, during pollen season because you're going to really feel sick and you're going to have lots of symptoms. So through this initial phase, sort of followed by an increase in these IgG4 blocking antibodies, and then eventually T regulatory cells have demonstrated some epigenetic modification. So moving to oral immunotherapy, I think that the most important point of this slide is that there's a single layer of epithelial cells, and it's really devoted to the rapid absorption of proteins. And we know that around 2 to 3% of intact protein is absorbed across either the M cell or through these villi, and can, in some cases, directly enter the circulation. There is a process of antigen presentation that is involved, and interactions with the adaptive immune system. And the other important point here is that tolerance is an active process. It's not a passive process at all. So let's move on to oral immunotherapy for peanut. As I said, oral immunotherapy studies have been conducted usually in smaller numbers for other foods, egg, milk. But let's focus on peanut allergy for a moment. And these are some of the earlier trials. And the point I want to make with this slide is that you can see the number of participants is rather small. The study design is variable across these studies. Some are single arm open label, some are double blind placebo controlled. The other thing to look at is that the target maintenance dose is different. So some have a target maintenance dose of 500 milligrams. Here's 4,000, here's 800 and 4,000. And then the duration is also different. So 7 months versus 24 months versus 44 weeks. And so it really wasn't until the sort of large scale, multi-center, double-blind placebo-controlled randomized trial that took place that sort of demonstrated efficacy for oral immunotherapy and led to FDA approval of OIT for peanut. So for this particular study, we randomized 551 subjects to either receiving the peanut product or placebo. And then at sort of entry, patients had to react at less than or equal to 100 milligrams of peanut during the double-blind placebo-controlled food challenge. And then they were randomized. And once they passed the oral food challenge, or they were considered participants or eligible for the study, they came back to undergo this sort of initial escalation. So this occurs in one day, and it allows for safety, to determine the safety of starting the peanut product at home. So escalating from 0.5 all the way to 6 milligrams, and then coming back on a second day to start the 3 milligram dosing. So these doses increased every 2 weeks, up to 300 milligrams, and that is the maintenance dose that they were placed on for about 6 months. And at the end of 6 months, they underwent another food challenge. So the key inclusion criteria, patients were 4 to 55 years of age, and the primary analysis population was in the younger group, 4 to 17. They all had a clinical history of peanut allergy. They all obviously reacted to a level of peanut less than or equal to 100 milligrams. They had positive specific IgE levels, as well as a positive skin prick test. And key exclusion criteria included severe or life-threatening episode of anaphylaxis or anaphylactic shock within 60 days of the challenge. They also couldn't have any eosinophilic esophagitis or any sort of EGID or GI concerns, or have an unstable chronic history of chronic asthma, or have mast cell disorders. And the primary endpoint for the study was the proportion of subjects in the pediatric population who tolerated a dose of greater than or equal to 600 milligrams with no more than mild symptoms at the exit challenge. And then, of course, key safety endpoints being, adverse events, frequency of allergic reactions, and premature discontinuation. And so looking at sort of the patient population, let's see here, the median level of peanut-specific IgE was 69 kilunits per liter in the treatment group, 75 in the placebo group, and then the size of the skin prick test to peanut was 11 millimeters in diameter and 12 in the placebo group. 72% had a pre-study history of peanut anaphylaxis, and the majority of subjects also had multiple food allergies. So in terms of the disposition of the patients, 842 patients were screened. There were a number of screen failures, either due to the inability to get to that, be able to tolerate the 3 milligrams, or perhaps flying and sailing through the double-blind placebo-controlled food challenge, and they weren't deemed ultimately allergic. But 372 subjects were in the treatment arm and 124 in the placebo arm. Overall, there was about 21% of subjects in the treatment arm withdrew, and then 79% completed the study. So this was the primary endpoint in the population 4 to 17 who received at least one dose in the food challenge. And that was the ability to tolerate 600 milligrams. So there was a difference between the groups. 67% of those in the treatment arm were able to consume 600 milligrams versus 4 in the placebo. And then if we look at this a step further and look at the higher dose, it looks like 50% of patients in the treatment arm were able to tolerate 1,000 milligrams. If we split this population into subgroups, looking at the younger 4 to 11 age group to the 12 to 17-year-olds, we see that 70.6% were able to tolerate 600 milligrams versus 61.2% in the older pediatric population. which suggests sort of a, an extra benefit, or maybe treatment works a little better in our younger pediatric population. And then when we look at sort of the median highest tolerated doses at entry and at exit, at baseline, the patients were able to consume 10 milligrams of peanut protein, and then at exit, it's 1,000 milligrams of peanut protein. Overall, systemic reactions occurred in 14.2%. There were 8 serious adverse events. 5 events in 4 participants led to discontinuation. And one of the events was a severe systemic reaction that was treated, and it occurred early in the therapeutic dose phase. There were no deaths associated with it, but 11.6% discontinued because of adverse events. So what were the main things that people were experiencing while on the trial? This is, the adverse events affecting more than 5%. Abdominal pain, you can see that as a biggie, especially in the dose escalation phase. 42.6% had abdominal pain, and then during the therapeutic dose range, it was 14.8% with an overall 52. So the majority of people have abdominal pain. Vomiting also occurred, as well as sort of, oral pruritus. So things affecting the GI tract were quite common, as were cough and throat irritation. And then in terms of systemic allergic reactions during the dose escalation phase, it was 8.5%. And then during the therapeutic dose phase, it was 8.7%. So systemic allergic reactions were occurring during the dose escalation, but also during the therapeutic dosing phase. And so it turns out that, if you look further at when reactions can occur, there are certain physiologic conditions or states that increase the likelihood of developing reactions while you're on immunotherapy. So this is kind of looking at a group of studies for OIT for peanut, and things like having fever, physical exertion, 2 hours before or after. It could sort of lower your threshold for reactions, menses, increasing the body temperature. So these are things that, in thinking about oral immunotherapy, really have to be part of the discussion in terms of whether this would be a good fit for a patient. So let's move on to epicutaneous immunotherapy. The point here is that there is sort of a strata or a large layer of non-absorptive keratinocytes in the epidermis, and it makes it a much more robust barrier with antigen passing through the epidermis via Langerhans cells. And there's very little vascularization in the epidermis, and so there isn't that sort of risk of a huge allergen load going into circulation. So those are the key points with epicutaneous immunotherapy, and likely the reason why there are few systemic and no GI side effects associated with it. So a few words generally about epicutaneous immunotherapy. There are over 200 patients that have been studied for milk epit. For peanut, there's over 1,000 patients that have been studied to date. And mostly there have been high adherence rates and low rates of severe or severe systemic reactions. So the study to discuss today is the one that was recently published in JAMA, and this is looking at the effect of epicutaneous immunotherapy versus placebo on reactions to peanut protein ingestion in children with peanut allergy. And this is sort of what the patch looks like and where the patch would be placed for a patient. And this was a randomized double-blind placebo-controlled study of 356 subjects. At entry, they all underwent a double-blind placebo-controlled food challenge, and they needed to react at or less than 300 milligrams in order to enter the study. If they were deemed qualified, They then received a 250 microgram patch. And this was placed on the back, increasing the exposure time every week over the course of about 3 weeks. And then there is this sort of therapeutic dosing phase that occurred over the course of 12 months, and that concluded with a food challenge. So the key inclusion criteria for this study were children aged 4 to 11 that had a clinical history of peanut allergy, had specific IgEs greater than 0.7 kilounits, and a positive skin prick test. And then dose limiting symptoms had to occur at less than or equal to 300 milligrams during sort of the initial food challenge. Key exclusion criteria was a history of severe anaphylaxis to peanut and any sort of chronic uncontrolled condition, including asthma. What's not on this list are conditions affecting the GI tract, EGID, EOE, etc. So the primary endpoint was the following. For patients that had an eliciting dose of less than or equal to 10 milligrams, they were considered responders if they could tolerate 300 milligrams of peanut protein or greater at the end of the study. For those patients that had a higher eliciting dose at the start of the trial, so greater than 10 but less than less than or equal to 300, which was the inclusion criteria, they were considered responders if their eliciting dose was greater than or equal to 1,000 milligrams. And then safety endpoints, of course, adverse events and serious AEs. So these are the baseline characteristics. The patients were randomized in a 2-to-1 fashion. And the median peanut eliciting dose for subjects was 100 milligrams with a mean of 140 milligrams. And the medical history of the subjects is in this table. 47% had asthma, 61 had eczema, 55 had allergic rhinitis, and 85 patients had multiple allergies. 500 patients were initially assessed for eligibility. 37 patients had a negative double-blind placebo-controlled food challenge, which is great for them. They couldn't do the study, but maybe they're not allergic to peanut. And then 356 were randomized, and 4 subjects eventually dropped out due to adverse events in the treatment arm. So this is the primary outcome. 35.3% of the treatment group versus 13.6% of the placebo group were considered responders, and this was statistically significant. However, despite the statistical significance in the proportion of responders, there was a pre-specified 15% lower bound of the 95% confidence interval of the difference between the treatment groups, and that was really not met. And so kind of despite this statistical significance, there was not enough superiority demonstrated to be considered a successful clinical trial. So there are other trials ongoing right now. More data has been submitted to the FDA, and they have recently submitted a BLA for a peanut patch product. So in terms of safety and adherence, there were really similar discontinuation rates between the two treatment groups. Treatment adherence was very high, and 4 subjects discontinued because of adverse events, 2 due to moderate anaphylaxis, and 2 subjects had rather moderate to severe reactions on their skin. And overall, discontinuation due to adverse events was 1.7%. The most commonly reported adverse events were local, site reactions. And so you can see that 57.6% of those in the treatment arm experienced site reactions. There were no GI AEs reported. So let's move on to sublingual immunotherapy. That's sort of the third method that we're going to talk about. Sublingual is not as far along in terms of large clinical trials as it is and has been for oral immunotherapy or epicutaneous immunotherapy for food allergy. As I mentioned, formulations of sublingual immunotherapy are approved for environmental allergies, and the one that's currently approved by the FDA in the pediatric population is that for grasses. And the amount of allergen that is delivered is really micrograms to milligrams, usually on the order of about 2 to 4 milligrams, and these are drops or dissolving tablets. There is no associated food taste or smell, and this is important for populations that experience an aversion to peanut, for instance, and wouldn't be able to tolerate it. So to summarize sublingual immunotherapy, it appears to have some modest increases in eliciting dose thresholds. And there have been some real creative ways of trying to improve the efficacy of sublingual by adding an OIT element to sublingual. And that seems to have demonstrated increased benefit when it's been combined for peanut. The major side effect, as you can imagine, is going to be oropharyngeal pruritus. And then finally, a longer duration of therapy appears to show some benefit. And this is just looking at a recently published long-term study of 48 subjects on 2 milligrams of peanut for 3 to 5 years. And this population's median exit eliciting dose was 1,750. There was no food challenge that was done, so we don't know the baseline eliciting dose for this population. So what are the questions we should ask before considering immunotherapy? I think the main thing is to really be eye to eye on what patients want, what families want, and what physicians want, and to make sure that that is clear. Is this a family that's looking to achieve tolerance? And we know that's not possible with what we can provide. Is this, a family that really just wants, to wear a safety belt so that, there's a buffer between, for when they're exposed to peanut and it would lessen the risk of anaphylaxis? And what's driving the need for treatment? Is it a life-threatening allergic reaction? Is it fear of unknown exposures, or is it a sense of lack of control? So there really isn't any single right answer for every patient. And so I think treatment's really going to have to be individualized. And there's going to be a balancing act between side effects, ease of use, and efficacy. And I think it may be that oral immunotherapy maybe ends up having the greatest efficacy, but maybe more side effects, whereas epicutaneous immunotherapy may have sort of the fewest side effects and maybe is not as much efficacy, and maybe sublingual sort of in the middle. But these are the main things to be thinking about as more immunotherapy treatment options become approved and are available for our patients. So this is really the matrix of factors that are going to determine sort of best care for patients. We talked a little bit about what the treatment goals are. Find out what the extracurricular activities are for patients. Is this someone who's in soccer practice 3 days a week? How is that going to work with oral immunotherapy? Is this someone who is in 2-parent homes? That might create some confusion about dosing. What's the impact going to be in school for patients who might have to come in to get dosing? And then, the age of the patient, we're seeing the younger patients are benefiting the most from therapy, and some of the older patients are experiencing more of the side effects and having the difficulty in achieving maintenance dosing. And how severe are the reactions? How high is the IgE test? We're seeing that there's a correlation with higher IgE and more difficulty in getting through oral immunotherapy. And then what's the risk of eosinophilic esophagitis? That's something that we haven't yet talked about. It's a theoretical risk for oral immunotherapy, And in fact, there are some reports of eosinophilic esophagitis developing in patients that have undergone oral immunotherapy. So if there's any concern for that, maybe the oral route's not the best one. And so, adding to this sort of matrix to help with decision-making is immunophenotypes. And this is phenotyping. This is what my colleagues and I are mostly interested in. And just to take a step back about what we can do in terms of testing and how accurate testing is, sort of on the far left is the standard skin prick testing. We've been doing that for decades. And this is, cost effective. You can get same-day results. And then there's blood testing that we can do, looking at allergen-specific IgE in this method. It's pretty comparable to skin prick testing, and you really don't have to stop antihistamines. So we use both modalities when we're evaluating a patient for allergy and trying to come up with predictions about whether they would react during an oral food challenge, whether they need to avoid it all, or whether they can actually introduce it, or we need them to come in to undergo an oral food challenge or an observed feed. The false positive rate for these types of modalities is up to 50%, so that clearly leaves a lot to be desired. There have been movements now toward implementing component testing, and component testing is a way of looking at specific components of a whole food to determine accuracy of testing. And it can provide some information on the risk of anaphylaxis versus something like oral allergy in peanut. But right now it's limited in scope, and it's not being broadly adapted, and it's really only available for specific types of foods. So what my colleagues and I are interested in pursuing is the development of antibody profiles for peanut allergic patients, to hopefully create predictive models for who might respond to immunotherapy. And so by, we've created this oligonucleotide phage library for every fragment of peanut protein. And if we take a patient's serum and their antibodies become bound to specific phage, we can capture that with magnetic beads. And a library of peptide encoding DNA sequences can be amplified by PCR directly using next generation sequencing platforms like Illumina. And from that, a count matrix can be developed, and then a series of statistical analyses can be done of the count matrix to determine peptide enrichments. And hopefully, we can begin to create a clearer picture about who is truly allergic. Is someone avoiding foods for no reason? What is the pre-treatment profile? Is it predictive of someone who would develop desensitization or sustained unresponsiveness? And then ultimately, what would the best therapy be for a particular individual? So our hope is that we can pursue precision medicine through shared decision-making, taking into account all of the individual factors that make that person unique, and aligning what the goals are of the patient, the physician, and the family, and then implement improved immunophenotyping so that we can provide some more prognostic data. And that will ultimately help us with response predictions and treatment. It may be that continued avoidance really is the best therapy, or desensitization with either oral immunotherapy, perhaps with the benefit of some biologics. Those are currently being studied. Things like omalizumab and dupilumab are being looked at as a means of trying to get some of the refractory patients up to maintenance dosing, and then potentially epicutaneous immunotherapy or other investigational protocols. So in summary, the FDA approved an FDA-approved therapy for food allergy is available for the first time this year. Immunotherapy is not a cure for food allergy, and I think at best we can hope for desensitization and possibly sustained unresponsiveness in a subset of patients. OIT, EPIT, and SLIT have various levels of protection, safety, and ease of use. Ultimately, choosing to pursue a therapy has to be a kind of a shared decision-making process, and improved methods of immunophenotyping are needed so that we can inform patients about outcomes. So I'd like to conclude by including this little picture of Lucian. His mom wanted me to share this picture of him. He's a happy little guy now. He had severe peanut allergy, went through the oral immunotherapy program, and is doing really well now. I'd like to, of course, thank all of the other patients and families that have participated in trials, the clinical allergy team, Angela, Lauren, Jasmine, and of course, Abby Sobiana. And then our clinical research team listed here, Tiffany, Kathy, Quinn, Heidi, and Liz. And then on the kind of lab side of things, Joe, Polly, and Kurt. So thanks so much for your attention, and I will be happy to take questions if there is time.
Thanks so much, Morna, for a fantastic presentation and a great overview of all the fantastic work that's been going on in this area. We have a few questions. I'm not sure how much time we have to go through all of them, but we'll try to get through as much as we can. So one of the first questions is there any data about maternal or prenatal diet and subsequent childhood food allergy, and are there things that we should recommend or not recommend to pregnant women?
Yeah, I think that the last time I reviewed this data, there were some in support of early exposure, but some that really didn't demonstrate any benefit to prenatal exposure. So I think, pregnancy is hard enough, and I think if it's within, your family or cultural practice to include some of these allergenic foods, then by all means go ahead and do so. Don't restrict it, however, because of any concern for prenatal exposure.
And then another question is it safe for oral immunotherapy for peanut allergy to be done in a pediatrician's office, or should this only be done in an allergist office? And as you answer that question, maybe you can also answer whether there are any locations in the East Bay to refer patients to.
Yeah, those are great questions. I think, with oral immunotherapy, it really, patients will react. I mean, there'll be various levels of reaction that can occur. And I really feel because of the sort of the experience and sort of the equipment and the training that is involved in preparing a site to start oral immunotherapy, it's really best done in an allergist's office. And I will have to get back to you on sort of the East Bay recommendation.
Thank you. Maybe one more question. For environmental allergens like grasses and hay fever, is there a standardized approach at this time to immunotherapy?
Yeah, so so immunotherapy for allergens is available, has been in practice for decades now. And for each individual patient, there's a specific recipe that really is developed based on the sensitivity or the reactivity on the skin testing, and then sort of the prevalent allergens in the environment that they may get exposed to. So there's not like a one size fits all. Each individual patient undergoing immunotherapy would get a special, recipe.
Thank you so much. It's 1 o'clock, so I'm going to give it back to Dr. Hirsch after a quick reminder that next week we have a special grand rounds on pain syndromes. So I hope you will all join us next Thursday at noon. Dr. Hirsch.
Thank you, Sodrain. And Morna, I'm going to try to squeeze in one last quick question, which is how long will tolerance last if you withdraw the maintenance therapy? Is that known?
Yeah, so that's been kind of the optimum state that we've been trying to pursue. Right now, it doesn't seem as though tolerance or sustained unresponsiveness is something that all subjects can achieve. In the studies that have looked at sustained unresponsiveness, the durations have been a removal of the agent for about 2 to 4 weeks, all the way up to 6 months. And it seems as though some subsets of patients can achieve sustained unresponsiveness when, that particular agent's been removed for a time of about 2 to 4 weeks. But I think tolerance is really not something that we've been able to achieve thus far.
So the patients really need to stay on the maintenance therapy then, long term.
Yes, yes.
Okay. Wow, great progress. I have a personal interest in this because my youngest son has a peanut allergy. So,
Yeah, it affects the whole family.
yeah, I'm certainly interested in how this is developing. And I want to thank you. This was a wonderful grand rounds. Thanks everybody for participating, and we'll see you all next week.
Bye, guys.
Bye-bye.